Bradyarrhythmias are very common and are super heavily tested. Today we will discuss the sinus bradycardia, the athlete's heart, all the AV blocks and the very interesting sick sinus syndrome. So let's get started. Before we start, let's quickly remind ourselves about the cardiac conduction system, as we will be using it a lot in this lecture. So here I have drawn the heart, right? This is the right atrium, the left atrium, right ventricle and left ventricle. This is the interventricular septum, and here what I have drawn are several dots. So what do they represent? The first one is the sinoatrial node. The sinoatrial node is the pacemaker of the heart. The impulse that depolarizes the whole heart generates there without any external innervation. So this is the sinoatrial node here. Once the impulse is generated, and by the way, you can go and check out Raj's videos about cardiac action potentials exactly to see how they generate. It's very high yield material for step 1 especially. So once it's generated here, it travels to the AV node, which is located right at the basis of the right atrium, whereas the sinoatrial node is located in the junction between the superior vena cava and the right atrium. So from the AV node, the impulse travels to the bundle of His. So this blue dot here is the bundle of His. And from there, the bundle of His splits into two, into the right bundle branch and the left bundle branch. They travel here in the interventricular septum. By the way, they're called how? The Tawara branches. And they end up with these little lines here, which are called Purkinje fibers. And they actually depolarize both ventricles. But wait a minute, we just said how we depolarize the ventricles, right? But how are the atria depolarizing? We actually have atrial conduction system, and it consists of internodal tracts, and we have 3 of them. So we have the posterior internodal tract, which is called thoro. We have the middle one that connects the sinoatrial node and the AV node again, which is called Wenckebach, and we have the anterior internodal tract, whose name I'm not sure of, and if you know it, please let me know. Now, this is how we depolarize the right atrium, but what about the left atrium? We have another branch there. It's an offshoot from the anterior internodal tract. So it goes like from here and depolarize the left atrium. And it's called Bachmann's nodal tract. Bradyarrhythmias are, in my opinion, very straightforward and very easy to learn, and I'll show you how here. There are actually several things that are similar for all bradyarrhythmias, so let's go over them quickly, and we're going to discuss each and every bradyarrhythmia separately in a bit. Also, let me know in the comment section below how do you feel about the AV blocks and the bradyarrhythmias in general. So let's start with the heart rate. Heart rate, as we all know, what is the normal heart rate? Between 60 and 100 beats per minute. So everything below 60 beats per minute will be bradycardia or bradyarrhythmia. And if you want to calculate the heart rate on EKG, how do we do this? Very easy. So if I draw here for example, if I try to draw, if these are the QRS complexes here, right? You have to count the large boxes between 2 QRS complexes. And let's say here we have 1, 2, 3, 4, 5, 6. Okay, let's say there's 6.5, but let's say 6 boxes, right? So if you divide 300 by 6, will be 50, right? So you just have to divide 300 by the number of large boxes between the QRS complexes. So 300 divided by 6 blocks that we have here is 50, right? So 50 beats per minute is your heart rate. The second thing the bradyarrhythmias you have in common is increased peer interval. What is the normal duration of a peer interval? It's between 120 and 200 milliseconds. So everything above 200 milliseconds will be some sort of bradyarrhythmia. But wait a second, what is the peer interval? What does it represent? So if we go back here to our heart drawing, the peer interval is the time the electrical impulse takes to travel between the sinoatrial node and the bundle of His. So it's basically the time between the atrial depolarization and ventricular depolarization. And here in bradyarrhythmias, the impulse just travels slower. to reach the bundle of his due to various reasons which we'll discuss in a bit. And here we have narrow QRS complex. The QRS complex represents the depolarization of ventricles, right? So now the narrow QRS complex we observe in sinus bradycardia, in AV block first degree and in Mobitz 1, whereas in Mobitz 2 and third degree AV block we're gonna have a wide QRS complex on EKG. Why? Because in Mobitz 2 and the third degree AV block, the block in the electrical impulse happens in the bundle of his or in the bundle of branches here. So as the impulse travels slower to depolarize the ventricles, we're going to observe wide QRS on EKG. Let's go over the causes of bradyarrhythmia. Always when a patient presents with bradyarrhythmia, think about reversible causes first. Like what, for example? Well, yeah, blockers of the AV node. It makes sense, right? If you block the AV node, the conduction will slow down. So what can block the AV node? Beta blockers? Yes. Calcium channel blockers? Yes. Digoxin? Yes. So look for these and stop them so you can improve the bradyarrhythmia. Now also check if the patient is having myocardial infarction, because it can lead to conduction block as well. Also, hypothyroidism is very important, as you know that the T3 has permissive effect on the sinoatrial nodal firing. So if you have low T3, the sinoatrial node will fire less. Also increased ICP, which stands for intracranial pressure, which presents with the famous Cushing triad, right? Increased blood pressure, decreased heart rate and decreased respiratory rate. And if the patient presents with Cushing triad, this is a very emergent situation and the patient can die in seconds, so he needs immediate treatment. Also, hyperkalemia can lead to bradyarrhythmias, especially when the potassium is between 5.5 and 6.5 milliequivalents per liter. This will lead to increased PR interval. And what is normal potassium? 3.5 to 5. Okay. Now, Lyme disease is caused by Borrelia burgdorferi, and we all know that it, in most cases, in 50% of cases, can lead to third degree AV block. In 20% cases, it will lead to second degree AV block, and in only 10% of cases can lead to first degree AV block. So the most common AV block in Lyme disease is third degree AV block. All bradyarrhythmias you present with one or more or all of the following here, like lightheadedness, dizziness, syncope or fainting or almost fainting. Chest pain can be present, hypotension, exertional intolerance. Also, they can have dyspnea, fatigue, palpitations, and even skipped beats, especially in the second and third degree AV blocks. Let's see how we can diagnose bradyarrhythmias. The first one and the easiest one is the resting EKG. The setback there is that if the patient is not having bradyarrhythmia right now, while he's in your office and you're performing EKG on him, you won't be able to catch the bradyarrhythmia, right? Now, the next one is exercise stress test. We can actually put him on the treadmill and ask him to start running or exercising. And what we're looking for there is chronotropic competence. Basically, if the heart rate can increase adequately with exercising. Number 3 is 24-hour Holter EKG. If the patient, for example, is having daily arrhythmias and he tells you that he's experienced the symptoms daily, then you can perform this 24-hour Holter EKG, so the device can record his EKG throughout the day, and you can see what kind of arrhythmias he's having. And the loop recorder here we use in patients who are experiencing very infrequent arrhythmias. So basically what it does, it activates itself once the bradyarrhythmia happens. It is also very useful for patients with syncopal episodes because it will again record the bradyarrhythmia after the syncope has occurred. And we're starting with sinus bradycardia. As the name implies, the rhythm is a sinus rhythm, which means that every QRS complex is preceded by a P wave, or every P wave is followed by QRS complex. Now the problem here is that the sinoatrial node is firing properly and it gets conducted to the ventricles properly, but the problem is that the sinoatrial node just fires less often. Apart from the most common causes that we just discussed, sinus bradycardia can be caused by the so-called athlete's heart, also called athlete's bradycardia or exercise-induced cardiomegaly. Why? Because of the hypertrophied left ventricle. Now what happens in athletes is the vagal tone, the parasympathetic system, is very active. It's very strong, which will slow down the sinoatrial node firing. And if you want to know the exact mechanism, check out our short videos on heart blocks and baroreceptor mechanism in the playlist of short 5 minutes videos for USMLE. And I can speak from experience here because I used to swim professionally for 10 years, and the most recent EKG that I did showed actually sinus bradycardia, and my primary care physician assured me that it was totally fine, it was normal, and that's what you should do for your patients as well. Now, sinus bradycardia, how do we treat? If it's symptomatic, we can give them atropine. And if you want to know the mechanism of action of atropine, again, please refer to our short videos. And if you do not find any reversible causes for the sinus bradycardia, you can start them on atropine. And again, the mechanism of action of atropine we have discussed in our 5-minute short videos. And if they ask you on the exam what is the definitive treatment for sinus bradycardia, answer pacemaker implantation. In first degree AV block, what happens is that the impulse that is generated in the sinoatrial node gets conducted to the ventricles, but much slower. Basically, there is a conduction delay in the conduction of the electrical impulse. So this delay in conduction will result in increased peer interval on EKG. Also keep in mind that in the sinus bradycardia there is no conduction delay there. So that's why inside the bradycardia the peer interval will be normal. So here also what we observe is again more than 5 large boxes. Basically the heart rate is much lower than 60 beats per minute, and narrow QRS complex. And if the patient is asymptomatic, very often in older patients, they do not need any treatment. The second degree AV block is divided into Mobitz 1/Venckerbach and Mobitz 2. By the way, you can check out our EKG video for cool historical facts on how to remember which was Mobitz 1 and Mobitz 2. And on that video there is a lot of integration, so I highly recommend that you check it out as well. Now on EKG in Mobitz 1, what we're gonna see is progressively increasing peer interval until a beat is dropped. So see, there is a P wave here, but there is no QRS complex. And this is happening in a P to QRS pattern. The most commonly ones are 3-2, 4-3 and 5-4. And here I have drawn 3-2 pattern. Basically 3 P waves, 1, 2, 3 P waves, and only 2 QRS complexes, 1, 2, and here where the question mark is the missing QRS complex. And once this cycle ends, it's gonna reset and it's gonna keep repeating itself, okay? Now, why is this happening? The problem is in the AV node here. So the AV node progressively fatigues itself until it blocks the sinoatrial node impulse and it does not conduct it to the ventricles. That's why on EKG, when this happens, we're gonna see or not see QRS complex there. And most commonly the Mobitz 1 is asymptomatic, but if it's symptomatic, the go-to drug again is atropine. In Mobitz 2 AV block, what we're gonna see on EKG is a sudden drop of a beat or sudden drop of a QRS complex. So as you can see here, the peer interval is constant and there is a sudden drop of a beat without any warning whatsoever. You also want to notice the widened QRS complex. So why is this happening? Because there is the problem in the His-Purkinje system here in the ventricles. They suddenly stop conducting the sinoatrial impulse. So that's why you're gonna see sudden drop of QRS complex. Now this AV block is very serious and it can progress very fast to third degree complete AV block. So if the patient is asymptomatic or symptomatic, you want to put a temporary transcutaneous pacemaker. And if the transcutaneous pacemaker is unavailable currently, you can start them on atropine. Just make sure that the patient does not have myocardial ischemia and you do not want to give them atropine in this case. Now, once you have ruled out reversible causes for Mobitz 2, then you have to implant transvenous pacemaker in all patients. In third degree AV block, what we observe is complete dissociation between atrial and ventricular depolarization. So the atrials are contracting on their own, the ventricles are contracting on their own, everyone is doing their own things separately. The EKG in third degree AV block can be a little tricky. The easiest EKG they can give you is something that looks like this. 3 P waves followed by 3 QRS complexes. It's pretty obvious that this this is a complete dissociation, right? But they can give you an EKG where the P wave is buried under the QRS complex. So there is no P wave. So you might wonder, oh my god, what is this EKG? Or they can give you an EKG that looks like the P wave precedes every QRS complex, right? Like the way it looks here. But what I want you to remember is how to differentiate the third-degree AV block from everything else. So look at the peer intervals. The peer intervals will vary in size and in length. So here this one is shorter, this one is longer. This is how you can differentiate it from MOBITS 2, where we said that the peer interval is constant. Alright, so also I want you to notice something here. The PP intervals and the RR intervals will be always constant. We said that the atria and the ventricles are contracting on their own, but they're contracting with a steady rhythm. That's why here the PP and the RR intervals will be constant and always constant. Now, why is this happening? The block actually in third-degree AV block can happen within the AV node. So if this is the case, which is in 2/3 of patients, we're going to see narrow QRS complex and heart rate between 40 and 60. If the block happens within the His bundle here, then we're going to see again narrow complex, right? But if it's a subjunctional block, which means that it happens below the His bundle, then we're going to see wide QRS and heart rate below 40. Why? Because when it happens under the His bundle, the ventricles will depolarize very slowly, which will manifest on EKG with widened QRS complex. What is very important to assess in these patients is if they're hemodynamically unstable. Why would they be unstable? Because of the decreased heart rate and resulting decreased cardiac output, right? So they can present with symptoms of altered mental status, hypotension, ongoing ischemic acute chest pain, even acute pulmonary edema, signs of shock. So if that is the case, you have to follow the ACOS protocol. You can start them on atropine. If it doesn't work, you can put temporary transcutaneous pacemaker. You can try giving them dobutamine or dopamine. And after you have ruled out again reversible causes, you have to implant transvenous pacemaker in those patients. And as promised, let's discuss the very interesting sick sinus syndrome. It's also called sinuatrial nodal disease because the problem is in the SA node. So here you can see all sorts of heart rates, fast, slow, alternating fast and slow, anything you can think of. And also the patient can present with syncopal episodes which are preceded by fatigue, dizziness, whereas as a comparison in ventricular tachycardia, for example, and the Torsades de Pointes, you won't have any preceding symptoms before the patient passes out. We have several types of sick sinus syndrome. The first one is sinuatrial nodal block, which presents with decreased heart rate. Why? Because the impulses travel very slowly through the sinuatrial node. The second one is sinuatrial nodal arrest, where the sinuatrial node pauses. That's why we're going to see skipped beats. And the third one is bradycardia tachycardia syndrome, basically alternating brady and tachycardia. And in between them, you're going to see flat line, asystole. And what can cause actually sick sinus syndrome? Well, most oftenly is caused by age-related wear and tear in elderly patients. Whereas in kids, we observe sick sinus syndrome where they have undergone some sort of cardiac surgery because of congenital heart disease, which has resulted in scarring of the sinuatrial node. And it can also present as a complication of atrial fibrillation, heart failure, stroke, or cardiac arrest. And the treatment of sick sinus syndrome depends entirely on the presentation. If it's bradycardia or tachycardia, you have to treat them accordingly. At the end of this lecture, I just wanted to quickly mention to you guys about the autoimmune congenital heart block. It's very high yield and it's very important for you to know about this. It's basically a complication of neonatal lupus. So imagine that the mom is pregnant and she has lupus. Around the 12th gestational week, she can pass through the placenta the anti-SSA, which is anti-Rho, and the anti-SSB, which is anti-La antibodies to the baby. So this can result in inflammation, fibrosis, and scarring of the cardiac conduction system of the baby. And unfortunately, we can diagnose this around 18 and 24 gestational week, and I'm saying unfortunately because if it's third degree AV block, which is most commonly the case, this AV block is irreversible. Of course, second degree and first degree AV blocks are also seen, but much less often. And this is the end of today's video. Make sure you know everything I told you, because these are all very tested points. This is all very high yield material and you want to know as much as possible. Also, stay tuned for the next cardiology video, which will be on infectious endocarditis and acute rheumatic fever. Thank you very much for watching. Have a super productive day and see you on the next video.